انا قلت له ايه السبب؟ لا خليها حضرتك.
بس هي ما فتحتش. انت اللي هتفتحها لي؟ الباشمهندس هيفتحها لي؟ ماشي.
It's a great pleasure to introduce our great professor, Professor Hoda Tamoum, Professor of Pediatric Neurology, for a presentation on MPS to change the science. Please, Dr. Hoda.
بسم الله الرحمن الرحيم. It's my pleasure to be among you. احنا شركة سانوفي طلبت مني ان انا اتكلم على ال MPS from the pediatric neurology point of view to raise awareness among pediatricians and pediatric neurologists regarding the early symptoms and signs of these disorders. So we are more or less chasing the signs where this theme was adopted by the National Society of MPS to alert the physicians to detect early symptoms and signs of MPS. By the way, الداي بتاع ال MPS كان قريب جدا يوم 15 ماي. I have this presentation is sponsored by Sanofi, but they did not interfere in any of the scientific contents of it. So MPS is a group of chronic and progressive lysosomal disorders characterized by defective degradation of glycosamine glycans. The first one was described by Höller, who is a female German pediatrician in 1919, and it is one of 11 disorders. And Höller was later on another syndrome, which is SHI, was defined in 1962 by another ophthalmologist from the USA. The pathophysiology of MPS is not just that the ungraded glycosamine glycans accumulate in the lysosomes and results in dysfunction of affected tissue and cause multiple organ dysfunction, but in addition, this storage will lead to later on apoptosis and mitochondrial dysfunction, adding to the burden of the disease. In spite of the different biochemical and genetic heterogeneity of all these disorders, they share common manifestations in the some in the cognitive and some in the somatic signs. But mind you, this statue dates to the 3rd and 4th century, and there is a similarity to a child with MPS, as you can see, protruded abdomen, genovalgum, coarse feature, short stature. So they say that this might be the first case to be described as MPS. MPS patients have a lot of symptoms because nearly all systems are affected: coarse facies, short stature, corneal clouding, glaucoma, retinal changes, recurrent respiratory infection, otitis media, hearing loss, valvular disease, heart failure, arrhythmia, hepatomegaly, splenomegaly, hernias, diarrheas, multiple skeletal manifestation, dysostosis multiplex, gibbous, scoliosis, hip dysplasia, genovalgum, and varus. So nearly all symptoms are there. We have 9 types. Type 1, which is the prototype, has somatic and cognitive affection. Similarly, type 2 and type 7, while type 3 is mainly cognitive and behavioral and minimal somatic, and type 4 and 6 are mainly somatic and minimum cognitive affection. Type 1, which is the main topic of us today, we have the Höller type, which has all the manifestations, and it presents early on in life and usually in the first 2 years, and life expectancy is severely limited to childhood. On the other end of the spectrum is the MPS SHI, which is these patients have normal intelligence, near normal life expectancy, but they have those skeletal manifestations and cardiac and pulmonary manifestations. In the intermediate is the Höller SHI, which has mild cognitive impairment, but still the somatic symptoms are there, and they usually die without treatment in the 2nd or 3rd decade. It's not difficult to diagnose these patients as MPS. So what we want is to early identify, because there is early treatment, so we need to identify those patients early on in life, especially in the Höller type, in order to start treatment before manifestations are established. So we are chasing the signs to what are the very early signs of the severe form. In the first 6 months, the main manifestation is inguinal hernia, abnormally frequent respiratory infection, otitis media, and possibly organomegaly. These are the first symptoms in the first 6 months. From 6 to 12 months, cardiomyopathy starts to develop with development of thickening of the valve, and you could hear a murmur. And again, the gibbous and other skeletal deformities start to manifest. From 6 to 12 months, as I mentioned, gibbous deformities, cardiac involvement, and again, we have still the umbilical hernia, mild hypotonia starts to have enlarged skull circumference, growth delay, and may start to have the coarse clinical features and corneal clouding. In the second year of life, now symptoms are there. So he starts to have cognitive delay, coursing of the features. As you can see in this child, there is broad nose, flared nostrils, prominent supraorbital ridge, thick lips, enlarged protruded tongue, starts to have joint contractures and claw deformities, starts to have gibbous, starts to have cornea clouding. So in the second year of life, the symptoms are more clear. Again, chasing the sign. So the signs that you should not miss: the claw hand contractures, the short statures, the corneal clouding, and the coarse features. But mind you that in type 2, there is overgrowth in the first 5 years, and then there is slowing of their growth after that. So this is the only exception. But these are not the early signs. These are the signs we should not miss, but these are not the early signs. In this study, in the Italian group, they looked into the early signs of MPS. And the earliest were recurrent upper respiratory tract infections and hypersecretions, hernias, liver and spleen enlargement, skeletal manifestations, and heart valve disease. Coarse features, which we usually look for, and cognitive delay are not early prominent signs. So we need to detect patients with these and not wait for the later on signs. So please remember that umbilical hernia is the earliest presenting feature in MPS 1 and 2, and inguinal hernias are reported in approximately 60% of cases. Upper airway recurrent infections and increased secretions are again common. These patients have frequent otitis media, frequent persistent nasal discharge, enlarged tonsils and adenoids, obstructive sleep apnea, hearing loss, whether it is conductive or sensory neural, and tracheobronchomalacia, which is a major problem because this can cause obstruction or collapse and may be one of the causes of death in subsequent years. Again, adenoidectomy, tonsillectomy, tympanostomy, together with hernial repair, are the more frequent and early surgical intervention in these patients, often performed before reaching the diagnosis. Coming to the central nervous system, as I mentioned, it's primarily affected in type 1 and 2. Type 3, it is the main manifestation, and again in type 7. The pathology is also the same, the undegraded glycosamine glycans and the secondary inflammatory cytokines and reactive oxygen species. Usually the children develop normally in the first month of life, and then by 12 months starts the slowing of the development, which start to be observed by the second year of life. And from 2 to 4, there is stagnation, and then after that, there is the decline. In addition to developmental delay, the language skills is usually impaired, part of it because of the brain affection, and part of it because of the hearing problem and the enlarged tongue. MPS usually, typically attain early motor mild skills, and then after that, it is related to limited joint movement and orthopedic manifestation and peripheral neuropathy rather than to the brain abnormality. A peripheral neuropathy, especially carpal tunnel syndrome, is common in these patients due to accumulation of glycosamine glycans in the synovium. Although all neuropathic MPS have behavioral changes, it is rather different. Type 2 and 3 are usually hyperactive and they are aggressive, while type 1 are usually placid and calm. And during adolescence, type 1 usually have low self-esteem, depression, and social withdrawal. On the other hand, type 2 and 3, as I mentioned, are hyperactive and impulsive and have some autistic-like features. Severe sleeping disorders and temper tantrums and easily irritability are common in type 2 and 3, and epilepsy. Type 4 and 6, as we already mentioned, Cognitive development is not affected, but mind you, the severe neurological complication can secondary affect the cognitive development. So if these patients develop hydrocephalus due to obstruction of the flow because of the atlantoaxial instability, or cervical spinal cord compression, or even the low esteem, again, because of the other disabilities, these patients may have impairment in their development. Okay. The MRI of the brain in MPS, we all know about the widened Virchow-Robin space, which is in the perivascular, as you can see here. These dots, these here. Usually they are in the periventricular or corpus callosum, around the corpus callosum. Again, there are white matter involvement, but what we have to look for is the hydrocephalus and the cervical spinal cord stenosis and thickening of the fluid. Coming to management, it is a multidisciplinary team because, as we can see, there are many systems affected. So you can expect that we need a team including all these, from dentist, dietitian, genetist, surgeon, cardiologist, neurosurgeon, psychologist, epileptologist, radiologist, anesthetist, neuroradiologist, physiotherapist, so forth. So we need a huge team. The management aims at slowing the disease progression and improving the quality of life. Palliative treatment and surgery are needed to mitigate symptoms, but at present, the disease-specific treatment for MPS are one of two: hematopoietic stem cell transplantation or enzyme replacement therapy. So nearly all MPS types have enzyme replacement therapies except type 3. So the focus of this presentation is type 1. So management of type 1. Number one, we'll talk about the hematopoietic stem cell transplant. This assumes that the transplanted cells from the bone marrow or the peripheral blood can penetrate to various tissues and organs and produce enough enzymes to alleviate symptoms. So since the donor cells continue to secrete the enzymes in the body, it is considered to be a permanent treatment. The main limitation is to find a matching donor and the rejection problem. When you transplant a patient with MPS 1, you stabilize. You do not recover. You stabilize the neurocognitive function, prevent fatal cardiopulmonary complication, and improve overall survival. So it goes by default that the earlier you start, the better you have the prognosis, because you are not reversing, you are just preventing. Although hematopoietic stem cell transplant may improve clinical manifestation, it does not affect a pre-existing cognitive impairment. And unfortunately, it does not reach the bone and the cornea. There is insufficient delivery of enzymes to these sites, so these do not improve with hematopoietic or prevent them. Very young, as I mentioned, the younger, the better the results, and especially if you can start before 9 months of age, you get an optimal cognitive, language, and adaptive, but still, nevertheless, you still have, some have decreased attention span and information processing and so forth. But it increases the survival beyond the 3rd decade of life. Enzyme replacement, aldrazyme, introduces a functional enzyme into the body to decrease or normalize the GAG levels. It's very effective in reducing the enzyme, improving the liver and spleen size, and this is observed after a few months of therapy. It reduces the number of upper airway infection, improves sleep apnea, improves the functional capacity of the lung, but it has no effect on the trachea or the bronchi. And mind you, the tracheobronchomalacia we mentioned before does not improve with the enzyme. And similarly, it has no effect on the macroglossia or adenoid and tonsils hypertrophy. Same like the enzyme replacement, the effect on the bone and cartilage is limited, and the effect in joint mobility is limited. Mainly if you start as early as possible, you have a better, but still it is limited even after years of treatment. As to the cardiac involvement, it improves the course of valve damage. The myocardial hypertrophy improves, and the enzyme replacement improves the geometry and contraction of the cardiac muscle. So to sum up, the weekly enzyme replacement improves the respiratory, and the cardiac symptoms, some of the skeletal and the joint, reduces the hepatosplenomegaly, and improves the overall quality of life. But the blood-brain barrier selective permeability hampers the enzyme to reach the CNS. So it does not prevent the cognitive impairment. How early you treat it, it does not. So if your patient is MPS type 1 and you gave him enzyme replacement therapy, if he is of the severe type, the early on type, unfortunately, it will not prevent the cognitive impairment. And similarly, as I mentioned, as similar to the bone marrow, it does not reach the cornea. So if you have, what is usually recommended, if you have a patient below 2.5 years of age and his IQ is above 70, try as much as you can to go for hematopoietic stem cell transplant, because age is optimal and still he has cognitive function and you don't want him to lose anymore. So if you can, this is the best. What if he is below 2.5 years, but his IQ is below 70? Is he worth a stem cell transplant? This is a debate. Some say that this low IQ is not worth saving anymore. But in his paper, Po et al. Studied the greater gain in cognitive development after post-transplant, even in children with low IQ. And he mentioned that the younger age, like 2 to 8 months, even with a low IQ, they benefit a lot. And even above the age of 2 years, they still benefit a lot. So whenever you can give a stem cell transplant, this is a very good option. Individual with intermediate phenotype, those who have mildly affected IQ, you can go both ways. Stem cell transplant, if it can benefit these patients, but you have to outweigh the risks and the benefit of transplanting a patient. Enzyme replacement is the specific and the best way to treat cases with attenuated MPS, because these patients have normal cognition. So you don't mind the fact, you are not worried about the fact that the enzyme does not cross the blood-brain barrier. It's no deal. So no need for hematopoietic stem cell. Enzyme replacement is the best for these patients. And also, if you have patients with MPS 1, and for a reason or another, you cannot give him the stem cell transplant, or the graft has failed, so you have no other option except to give him the enzyme replacement. So the use, as I mentioned, the use of enzyme replacement in cognitively involved patients is a subject of debate. The most accepted position in the scientific community at present is to give the enzyme replacement to any patient if you cannot have, because of the potential that it will improve his other somatic symptoms, nevertheless knowing that it will not improve or prevent his cognitive impairment. What's nice is that there is a European consensus that a panel treatment algorithm has highlighted the benefit effect of enzyme replacement in pre-transplant patients in terms of respiratory and cardiovascular function. So when you are still preparing your patient for stem cell transplant, you can give the enzyme replacement. It will improve his respiratory and cognitive and systemic and cardiac functions in preparation for to get the benefit, the best benefit of that transplant. Again, co-administration of both the enzyme replacement and stem cell are shown to be well correlated, with no increased risk of immune-mediated complication or graft versus host or graft rejection. So currently, many transplant centers give both, give enzyme replacement prior to the stem cell and maintain it for 6 to 12 months until the donor cells kick and they take over and they can replace the recipient cells. So as I mentioned, this combination has proved to be associated with a better outcome, indicating that management of MPS requires combined and multidisciplinary treatment. However, whether enzyme replacement should be continued after the 6-12 months needs further evaluation. So early treatment, better prognosis. The outcome is usually worse when you treat later. So if enzyme replacement treatment is the choice, it probably should be initiated as early as possible. So this algorithm is very nice. And this is the one we want to alert all pediatricians to. If you have a patient below 2 years of age and he has kyphosis or gibbous deformity, go ahead go ahead, خلاص, go ahead for assessment for severe phenotype of MPS. Nothing to do anymore. Go ahead for assessing for MPS. If he does not have kyphosis or gibbous, but he has two of hernia or hernia repair, recurrent ear, nose, throat infection, coarse facial features, developmental delay, hepatomegaly, joint stiffness or contractures, cardiac valve disease, or hearing loss, any two of these, you should suspect a severe MPS and go for investigation or send him to a specialized center. If your patient is above 2 years and again has kyphosis or gibbous, again, go ahead for a specialized center. If this is associated with cognitive delay, you expect him to be a severe type. If it's not, if this is an attenuated type, but again, just the presence of gibbous or kyphosis or joint stiffness should alert to MPS. And if two or more of hepatomegaly, coarse features, growth velocity decline, recurrent ENT, recurrent surgeries, cardiac valve disease, hernias, cornea clouding, developmental delay, and carpal tunnel, any two of these should alert you to send him to be investigated. Joint stiffness. So what I want to say is that joint stiffness without inflammation and kyphosis or gibbous are highly specific presenting signs and symptoms, and on their own are sufficient to raise the possibility of MPS. The patient should be referred to the metabolic or genetic specialist without delay. And as Dr. Omnia mentioned, there are many centers all over the world and all over Egypt, and they accept these patients and do for free the genetic test for them, even if it is just based on suspicion. And they did not limit us at all in our suspicion. So anything that goes like possible MPS, please remember to send them, the earlier the better. And urinary gag testing may be performed to facilitate the diagnosis, but if negative and you still think that he's convincing, please seek an appropriate evaluation. There are newer therapies, like whether enzyme replacement can be given intracerebral or not, intrathecal or not still, about in vivo gene therapy, or substrate reduction, where they are looking into decreased synthesis rather than instead of increasing degradation. But still, these are all options later on to be evaluated. So in conclusion, due to their severe and progressive symptoms, MPS requires keen awareness among pediatricians and other specialties to shorten the still existing diagnostic delay. Early diagnosis is imperative to prevent organ dysfunction and improve the quality of life. Although many of these features have other possible causes, they should promptly arouse suspicion of MPS. And this is the point we want to raise. Do not wait till you are sure that your patient is MPS, then you are too late. Referring the patient to metabolic center will allow early recognition. Thank you.
Thank you very much, Dr. Hoda, for your excellent talk. Is there any question? No question? Could I ask you, how many patients have you performed hematopoietic cell transplantation in Ain Shams? And
I
how
refer
many?
this to Dr. Ola. She is more aware of I refer this question.
For our MPS patients, we do have mainly patients who would refer to hematopoietic stem cell transplantation, but actually بيحتاجوا لازم ويدوا ليهم يعملوا زي قضيه ويروح عشان يحصل لهم. يعني في one patient can already candidate for that. لكن what I did, my experience, I have a lot of experience in King Faisal Hospital, Saudi Arabia. All patients who do have a committee for patients less than 2 years of age, and also regarding the IQ, and we do have really a good number of patients with favorable outcome who did hematopoietic stem cell transplantation early.
Thank you very much. We will close the session, and we are inviting chairpersons for our next session.
بسم الله الرحمن الرحيم. We will start our session.